All right. Okay, super. Well, welcome everybody to today's podcast. I'm Simon Pimstone, the founder and CEO of XYON Health. With me today from XYON is Dr. Christina Han, our medical director. Hi, Christina. Christina is clinical assistant professor at the UBC Faculty of Medicine in the Department of Dermatology and Skin Sciences. Christine is a practicing board-certified dermatologist here in Canada, as board-certified in the US, and thrilled to have you helping Christina get to the truth with our special guest today, Dr. Sara Wasserbauer, who runs founder and runs the California Hair Surgeon Clinic. Dr. Wasserbauer really doesn't need much introduction, but I will give a quick introduction. She is a member of the board of the American Board of Hair Restoration Surgeons, and previously has been, and in fact still is, on the board of governors of the International Society of Hair Restoration Surgery. Dr. Wasserbauer is an internationally renowned speaker and extremely well known in the field. Has an interesting background, internal medicine trained, and I see actually you did a degree early in archaeology, which is quite something for a hair restoration surgeon. So
yeah, I worked for Apple as well. So
oh my goodness.
Random.
Well, amazing to have you. We're very privileged to have you here, Dr. Wasserbauer. And Dr. Wasserbauer will be helping us deconvolute all the myths and truths on hair loss in the younger female patient, particularly focusing in the premenopausal patient, where we do see hair loss, and probably I could say increasingly see hair loss as a phenomenon in younger women. And we have lots of questions for her, and we have lots of questions that have come in from our audience as well over time. So thrilled to have you. I'm going to kick off, and we'll do a bit of a tag team with Dr. Han and I in asking questions. But perhaps, Dr. Wasserbauer, we can start at a very high level, which is in women. If you could maybe just talk to us a little bit about the key causes of hair loss that you see, and then perhaps break that down into menopausal and postmenopausal females versus premenopausal females, just the types of disorders that you will typically see in your practice and women should know about in terms of causality of hair loss.
Yeah, they're unfortunately for women, the things that cause hair loss are as long as your arm. For men, it's genetics and the hormone dihydrotestosterone. But for women, there's just a myriad of things. So in the premenopausal category, you'll often find thyroid, fast weight loss, medications usually affect our female population more than our male population, and of course, genetic hair loss. So when we say hair loss, we're actually talking about losing hair mass. If you ask a woman, what they experience when they're having hair loss, they'll say, well, my ponytail, I got to wrap it around 3 times instead of 2, or you can see my scalp a little bit more, or I just see this shedding all over the place. In postmenopausal women, it's very similar to that, but there's an age-related component. So you'll have things like thyroid, low protein or fat diets, weight loss, but the age-related component, we just don't grow hair as well when we're 81 as when we're 18. And a lot of us remember 18 a lot better than we envision 81. So those smaller and smaller hairs, kind of like think of your hair as a tree, and it's instead of growing like an oak tree, now it's growing more like a sapling. And that's really where women feel when they're running their fingers through the hair, they feel, less that they can work with. And that's a big cause. So there's almost, 15 medical causes that contribute. And generally speaking, in both premenopausal and postmenopausal women, it's usually not just one thing, but often those underlying genetics will really push them towards some hair loss and coming to see, one of us.
What role does genetics play as you look at the history in a patient, and how important is their family history of hair loss? A woman comes to see you at any age, has thinning either in her father's side or her mother's side of the family. Does that often point you a bit more towards sort of genetic factors that may be at play, and how might that change your approach to treatment if that family history is very strong?
It definitely, it's something everyone comes in and says, hey, my mom had this history of the hair loss. My sister's experiencing it. It may not be the number one factor, but it's, everyone who, dermatologists included, can tell you it's usually one of the big factors. So it will, in addition to other things that are going on, they have changed medications, they have, a thyroid problem, they have a low protein diet, they have all kinds of other, maybe polycystic ovarian syndrome, something that would kind of the 2-hit model. This isn't necessarily established science, but it's usually not just one thing. Usually it's several things all in conjunction that are causing that. And to your question, genetics is almost always one of those components.
And we hear a lot about whether it's from the mother's side or the father's side. Our understanding, of course, is that it can be either. So it's really a myth that it comes from the mother's side, and you would agree with that.
Yes, absolutely.
Great. If we hone in a little bit more on the premenopausal woman, questions we often get asked, which perhaps we can talk a little bit about. You've obviously talked about a number of medical disorders, hypothyroidism, low thyroid, anemia, polycystic ovarian syndrome, often associate with hair loss in a younger woman. They need their own investigations and their own treatment. What about postpartum? We see a lot of young women, either pregnant or after delivery, who complain of hair loss fairly acutely. And perhaps you can also talk about stress as an etiology, TE as an etiology, and you can explain to the audience perhaps what TE is. And this has become quite an important factor during COVID, I think. A lot more women seem to be coming in talking about thinning hair. How much does that stress, or how much does TE play a role?
Well, when you're talking about thinning hair and the genetic hair loss that's slowly progressive over time, you have to contrast that with TE, which is just, doctor speak for telogen effluvium, a big shed. So if you're talking about a big shed, that can come from those big events, from a big life stressor, usually not immediately, usually 3 to 6 months after. A large change in your hormones would be after, giving birth, after a big sickness or an illness, particularly if you have a high fever. Those will precipitate a big shed. But a big shed, you have to liken it back to the forest, is kind of like the trees have decided that they want to grow a new tree. And so the whole tree will be uprooted. So now instead of 100 trees per acre, you have 80 or 70. But those trees aren't dead and they're not thinning. Even though it feels like thinner hair and you see a lot of shedding, it's actually distinct from the slow progression over time of the oak trees becoming saplings. That's not what telogen effluvium would be. Telogen effluvium would be a whole bunch of the trees decide to shed at once. You have fewer trees per acre, but there's a high likelihood that those will regrow. And that's kind of where we get into knowing what that cause is, whether this is a telogen effluvium or whether this is genetic hair loss or iron deficiency or whatever. Then that shows you which treatment arm you should kind of proceed down.
So I think you're telling us essentially the etiologies or causes of hair loss in younger women can be complex, meaning multiple different factors. It's very important for women who are listening, as they have or experience hair loss, to see someone who can really try to break down whether this may be genetics, whether this is a stress event, whether this is an underlying medical condition, which may require much more in-depth investigation and treatment. And really, it's not a one-size-fits-all for women complaining of hair thinning or hair loss. I've got a ton more questions. I want to obviously dive into some of the psychosocial factors because, of course, hair loss in a woman is extremely distressing. In men, you're almost sort of supposed to go bald, but of course, in women, when hair starts to thin, it becomes extremely distressing. I'd love to get your thoughts into some of the emotional oversight and how can we help women in this regard. But I'm going to hand over to my colleague, Dr. Han, who's, I think, got some questions on treatments of different disorders. So, Christina, please, over to you.
Oh, no problem. Thank you. No, I really liked how you guys highlighted the differences between telogen effluvium versus the genetic component of female pattern hair loss. Before we move on to that component, though, you highlighted some important life events like postpartum, as well as hormonal causes. and medications. And one that's commonly used right now is Ozempic, and that's sometimes a trigger for a lot of that big shed hair loss that we see. And I certainly see that in my practice. And we know that that can be very distinct from the genetic hair loss. But I often counsel my patients on this unmasking ability that sometimes this telogen effluvium can have on the genetic component. How do you sort of manage and counsel patients on if there is a potential link between the two?
Well, just as you said, I mean, you were very succinct. When you go through an event that triggers that shed, because hair is constantly cycling, you got to think of it as the hairs are constantly going around this flywheel. But if you speed that up, like you go through a telogen effluvium, if the hairs have been slowly getting smaller and slowly getting smaller, now you've shed, so you've accelerated all the hairs into one more cycle. So everything is going to go a little bit like that. So that's the unmasking that I would agree with you really happens when you go through a massive weight loss. And that can be Ozempic. It can be, anything. Bariatric surgery happens a lot. Estrogen generally is protective. So if you are changing your hormones or you're postmenopausal, you don't have as much estrogen, then your hair isn't going to stick around as easily or grow as robustly. So we counsel with a lot of compassion. It's so emotionally wrenching. I mean,
Oh, for sure.
Yeah.
The bulk of my practice is, women.
Yeah, exactly.
Yeah.
Most women define themselves by their hair. I would add one more thing, and that is a seasonal shed. So there's some studies that show that around the world, October and May are the months when humans in any country have the least amount of hair. So if you time the shed with that kind of calendar, then you can also say, well, this might be a seasonal component superimposed on top of all of this. And just by way of explanation, I brought with me a visual aid, and that is my own hair, because this year I went through a seasonal shed, and it's just starting to grow back now in November. And this is, this is the new hair growing in. So patients will go through these sheds, and I just went through it and I documented it so that other people can understand.
That's super interesting.
It's hard to relate to the the huge shed and how much emotionally it is. And I knew what I was going through, and it was just devastating for me as well. I just wanted to wear a baseball hat the entire time.
Oh, for sure. For sure. Super devastating, often tearful patients in the room. So absolutely a big psychological component. I'd like to shift the focus to female pattern hair loss in the young female. And ones that often present to us, I think, are the ones that are more moderate to severe. And I kind of wanted to get your sense on how you approach these, whether you approach these with really aggressive oral therapy, monotherapy, topical therapy. Do you do combination therapy? So say you have a young woman sitting there with, really devastating thin hair that looks more genetic. How do you sort of approach these?
Well, I mean, obviously a full workup to see if there's additional things that we can treat. Anemia, low iron, even if you're not frankly anemic, usually adding iron, the hormonal component. But if it's simply genetic and everything else is rock solid, you nailed it. It's a combination therapy. So we would not only we'd try oral therapy, but we would also do topical in addition to, adding more protein to the diet, adding more, whatever medications we can do. Low-level light therapy is a huge boon, especially if you can, get the light to the scalp, which is, that's my one thing about photobiomodulation, which is low-level light therapy, is getting the light to the scalp. But everything seems to add another couple of percentage points, and everything also seems to work together so that if, let's say, you're using minoxidil, which is Rogaine here in the United States, and low-level light therapy, if either one alone is giving you, I'm just going to make up numbers, a 10% improvement. So minoxidil giving you a 10% improvement, low-level light therapy is giving you 10% improvement. Together, they give you like a 30% or a 40% improvement. These aren't exact numbers. I'm just using that to illustrate that combination therapy really, like they used to say, throwing the spaghetti at the wall and seeing what sticks, using everything that you can, because it takes a whole year for that hair to grow. So
Yeah,
if you're
absolutely.
you want to get the hair to grow, it's a paradigm shift. I think you'd agree, Dr. Han, that when you're taught medicine, you try one little thing and come back in 2 weeks, let's see, and you do a blood test. That's not the way it works with hair, because hair takes a year to grow, whether I'm doing a transplant or anything else, whether it's the medication. So if you do everything all at once, you see how good you can get the hair to grow. And then you can scale back, peel back the layers instead of, and eliminate things instead of just, waiting to see a whole year whether something gives a benefit. So it's a paradigm shift.
Yeah, I definitely absolutely agree. And I think it goes to the messaging that I'm always trying to explain to patients. The earlier you treat, the more, benefit you're going to get, but also the more aggressively you treat, the more maintenance you can get of those follicles. Because really, ultimately, we're trying to prevent that miniaturization process. And it's really hard to reverse that once it's been impacted for an amount of time or without treatment. So I completely agree.
If I can just add, Christina, I think this is a very interesting point, because if you think about many chronic conditions in medicine, and I'll just use hypertension, high blood pressure as an example, I think there's really a belief that tackling it with different modalities of treatment to affect different mechanisms of that disorder, in this case, hypertension, or you can substitute it for hair loss. Having multiple modalities of treatment used in combination is generally thought to be a preferred approach. And I think this is a very important concept. You've made a couple of really important points now. One is early treatment is important. The sooner you treat, the more likely your outcome will be better over time. And the second is, try to get, if you need aggressive treatment, you may need multiple therapies to optimize your response. So I think these are very, very crucial concepts for patients to understand.
Yeah, and I think it's especially so for the female patient, just because the pathogenesis of hair loss in this population is just so much more complex than it is in the male hair loss space. And I'm not sure if Dr. Wasserbauer agrees, but certainly it's not all just blamed on the whole DHT story in the female population. And I think hitting it with multiple mechanisms when it comes to pharmacotherapies or also surgical modalities or other things that you touched on, like diet and lifestyle and treatments like, low laser or low level light therapy. So, there's different things that can be done from different modalities. So touching on that, I guess I wanted to get your thoughts on specific therapies. Minoxidil is becoming more popular in the oral format. And I'm wondering where you use this, or if you have a place in using this in the younger female population. I certainly use it. I still also do use topical minoxidil as well. So seeing where this sort of fits into that space in your practice.
The oral is excellent. I'm also speaking as a surgeon, and the anecdote I like to share is I have had several of my former transplant female patients come to me and need additional therapy to manage their ongoing progressive loss. And we put them on oral minoxidil, and they come back and they say, Dr. Wasserbauer, this is the best thing you've ever done for me. And all I can think of is, but wasn't I great with the hair? So, my ego gets a little hit there, but yeah, they come back with remarkable stories. And I think the oral has been revolutionary because it allows us to target the hair follicle. If you look at the previous, and I realize XYON is, part of our discussion today. If you look at the previous formulations for topical medications for hair, it's very difficult to get medicine to help hair, because in hair-bearing tissue, you're going to get most of it on the hair. How do you get it to the scalp where it needs to be absorbed? The second thing is hair on your head is so difficult to absorb. Dr. Han, you're going to be an expert in this. The thickness of the tissue, the stratum corneum, the oil glands, there's so many sebaceous glands, highest concentration of oil glands is on your scalp. So getting the medications absorbed without getting into too much detail has been miserable. Plus, there's that psychological component of, well, I'd rather take an oral because in order to put something topical on my head, which may be highly effective, I have to touch an area that I wish would just go away. And in order to do that, I have to acknowledge that I have a problem, right? who wants to do that? I don't want to acknowledge that I need to eat less ice cream. So every patient will say, well, I didn't really like the topical, or they'll lie and say, yeah, it's just not working. It's usually just sitting on their bathroom shelf. So in order for it to work, it has to be useful. Yeah. And so, getting formulations that will go towards that, whether it's an oral or a topical that actually is a little easier for patients to put on, that's the key. Some people say, well, which one do you like better? I like the one better that a patient will take or a patient will use, because then we'll get efficacy. It almost never fails.
Yeah, and that's certainly true. Patient preference is big in dermatology, as we use lots of topicals for different things. And sometimes it's just a matter of patient preference. Yeah. So that's a good segue into the use of topical finasteride and dutasteride. That's becoming very popular as an off-label option for many men and also women, particularly women that are postmenopausal. Is this something you incorporate into your practice? And even so, do you even use it in young women, given its potential for teratogenicity?
Yeah, I've used it in the oral form for a really long time. The topical form, here's where I battle the misinformation of the internet. You have to understand that, dutasteride and finasteride are large molecules that are not necessarily, I have so many patients just grinding them up and rubbing them onto their head. That won't do anything. Even if somebody's blog somewhere on YouTube says, oh yeah, no, here's what I did and I grew all my hair back. They're lying. And as a matter of fact, you know that they're lying. Otherwise, you wouldn't have made an appointment with me to come and ask me whether or not this is true. So it's clearly not effective. Otherwise, everyone would be doing that. I'm really hopeful because there's so much new technology that's helping us with the topical finasterides and dutasterides of the world. The topical sprays they might not get to the scalp. Usually, if you have any kind of length to your hair, you're going to get it just on the hair and not to where it needs to be. But a lot of the new formulations are overcoming the barriers of the amount of oil that's on the scalp, the pH, the somehow disrupting the stratum corneum in order to get that down there. Like there's new ultrasound technology that might help us get dutasteride and finasteride into the scalp. But that would also necessitate, doctor's visits. There's not ultrasound home therapy. So I think for now, in order to get good topical use, you're going to have to be in one of the newer formulations. And just putting finasteride into a spray hasn't really been the panacea that we all hoped it would be. Right. And when I say we, I mean patients and doctors. It's always clickbait that makes me laugh. Say that the hair loss secret doctors don't want you to know. I always crack up. I'm like, the whole reason we got into this, Simon, you can speak to this too. The whole reason we got into this was to help patients. And maybe we even had hair loss ourselves. So we were wondering what we could do, that had real evidence. And that's, I think, where a lot of patients maybe I should make a phone call with a doctor or somebody who actually knows what they're talking about, because there's so much conflicting misinformation on the internet. So don't believe all the topical dutasteride, finasteride. Some of it is truth, which is what makes it so confusing. There's always a kernel of truth, but a lot of the claims are not borne out by actual science, unfortunately.
Yeah, I'll just make a comment, Dr. Han, perhaps before you jump in, is that I think Dr. Wasserbauer has made a really important point. Not all topicals are created equal, which is what we say. So I think for the patient to really understand with their doctor some of the limitations of topical administration, as Dr. Wasserbauer says, particularly dutasteride, a large molecule, very lipophilic, meaning it likes fat. It's not aqueous soluble. How do you get that into a formulation as similar with finasteride that can deliver the right amount to where it's needed and limit that systemic absorption? Otherwise, you're just effectively doing an oral. And how do you do it in a way that maximizes the delivery of those medications is not that straightforward. You don't just put a drug into a solution and put it on your scalp and hope it works. So I think those are some very important points that Dr. Wasserbauer has made.
One more PS to that is a lot of patients will come to me with something they got on the internet where the finasteride or the dutasteride or even the minoxidil has been put into a shampoo. How nice would that be? unfortunately, most of the shampoos that are medicated that will actually work have to be placed on the head and left for a good 5 minutes, like even a dry scalp. And 95% of the ingredients in a shampoo go right down the drain.
Yeah.
This is from an old friend of mine named Tom Dawson, who used to be a Procter & Gamble, head of Procter & Gamble's head research for 27 years. He's done a TED Talk on it. So it's not so straightforward as Simon said. It's not, I just got that. Simon says. Anyway, it's not as straightforward. And patients come all the time and say, show me the little bottle that they got. And it might as well say snake oil right on the front.
Yeah. Well, no, I appreciate all of that. That's great. The last thing I wanted to ask was that there are going to be young female listening to this, and they may be family planning. What are their options if they're planning to start a family, or even in that postpartum phase where they're breastfeeding? What really are the options for those patients?
Good question. A lot of the studies in pregnant or lactating females are limited. So you're not going to have a good set of data. In medicine, we have all these different levels of data. And you would love it if you had something that really showed that this group of women who was a control group and this group of women who was actually taking the real medication was evaluated to be, have more hair. I'm not sure we're ever going to answer that question because of the possibility of affecting a fetus. And there's a long history of thalidomide, all kinds of things that, things weren't tested in females who are pregnant or lactating. And of course, I've had 3 children. I was scared to death. But I will say that usually, even in my females who have very early young female pattern hair loss, their hair grows the best when they get pregnant.
Yeah.
And usually they'll go through the dread shed afterwards. And so sometimes because of that hormonal boost, we will hold off on the medical therapy. I would love it if we had a topical that I could be convinced wasn't going to go systemic. So the minoxidil formulations. And often if you get 10 OBs in a room, OB-GYNs in a room, they would probably say, yeah, it's very likely that the topical minoxidils are going to be okay, but we just don't recommend them because they happen to be the most sued subspecialty of medicine anywhere. So they're not going to, come right out and tell you, oh yeah, it's totally fine, because they just don't have the data and no one ever will. So I kind of let my patients make a decision for themselves. If they are family planning, pretty quickly these days, you pee on a stick within a week or 2 and you're going to know whether you're pregnant. You can stop at that point. Or you can not take anything at all and know that the hormones are probably going to make your hair grow really well. So it's not an easy answer for that particular question, but often, if it's something that we could limit to the scalp, that would be wonderful. And maybe the topicals really are limited enough that they don't have the exposure to the fetus.
Yeah, I think this is very important work, and as is often the case in medicine, as the point you've made, so little data is available for this population of patients who often have a medical need, but you just don't know about safety. So I think the message is always be cautious first, but at the end of the day, it becomes a discussion with the patient to determine their risk tolerance or not. And as physicians, we're there to help them through that decision. But this is actually a very interesting segue, perhaps, Dr. Han, into other modalities of treatment that may be less pharmacologically oriented. So we talked a bit about low-level light. We've talked, or should talk, a bit about exosomes. There's a lot of buzz around exosomes of various origins, including potentially plant-derived. And then, PRP as an example. So just how do you approach those modalities in your female patients, and what do you advise them as it relates to other types of treatments for their thinning hair?
Dr. Han, did you want to take that one first?
Sure, yeah. For me, I think I'm practicing in an evidence based fashion. There just isn't a ton of evidence. I do have a lot of patients out of the modalities you spoke on doing PRP because it's so readily available locally here, and I think everywhere in North America. So a lot of patients do go with PRP. The problem is that there are no set guidelines or standards on the regimen, the amount, and the size of the needles. And so I think really I'm fine with patients doing it as long as they're going to a nice regulated facility that has a physician that's delivering the treatments. But really there isn't a ton of guidelines on this. And so I do think it's really more adjunctive therapy. I don't really recommend it as primary therapy. And then I think the evidence is softer in the space with exosomes, even more so. I actually spent some time as part of my dermatology residency in South Korea doing dermatology there and doing hair. And this was more than a decade ago, and they were implementing low-level light therapy into their clinical space. And so I did see some evidence of its use being done there, delivered by dermatologists for patients with really good results. But this was also done in conjunction with other therapies. So it's really hard to say on its own whether or not it's really good validated monotherapy. But certainly it is heavily used in other parts of the world. And now it's become even more readily available for patients to just do on their own in the comfort of their own homes. So certainly I view it more as adjunctive. Dr. Wasserbauer, do you have any additional comments or differing ways that you counsel?
I'm in violent agreement with you. First of all, low-level light therapy, 100%. I would love it if we could get to the place where we have devices for consumers that are dosed correctly and have the ability to get light to the scalp. I happen to be in a unique position. One of my brothers is a patent attorney, and the other one has a PhD in photonics. Photonics is is light engineering.
Light, yeah.
Yeah. So my end of the Thanksgiving table is highly technical. And we've been discussing this for years now. And even 2 millimeters of hair, not that my female patients are going to be shaving their head, but even 2 millimeters worth of hair will reflect or get rid of between 34 and 37% of the light transmitted. So it's not as simple to get the light to its target as we would like it. I mean, everything is difficult, but it is an excellent adjunctive. Like, pile them on. Low-level light therapy will not hurt, may help. Go for it. And it's easy. You put a hat on your head, you press the button, you're done. Mm-hmm. I like to put the PRP exosomes into one big category of growth factors. So that's what's inside of exosomes. The whole reason people are trying to inject them from various sources is because they have growth factors inside. And platelet-rich plasma, the platelets have growth factors inside them. We're trying to get those to the hair follicle. The injectables, I find the variability, it's like you said, Dr. Han, apples and oranges. There's no set rules. And this came out, there was a big seminar September of, I think, 2022 or 2023, where all of the people around the world who've been doing research into platelet-rich plasma came through the American Hair Research Association, and they came together and they said, okay, let's have a symposium to talk about what works, what doesn't. It turns out too many platelets sometimes is inhibitory. Too few platelets obviously doesn't do that great. Platelets vary on a day-to-day basis, so you never know what you're injecting, even if you actually have a way to count the platelets and get the 3 to 5 times concentration that somebody came up with might be worthwhile. So after measuring the cross-sectional diameter hair measurements of all of my patients going through PRP and finding these wild variations, sometimes they'd get a benefit of 150%, sometimes it would be 11%. So after doing that, I'm hopeful that the new kind of ultrasound assisted growth factor, that'll be much more consistent. I'm hopeful that, growth factors would be able to be infused in other ways. I like the idea of growth factors. I think that has merit, But the way that we've been really trying to, again, we're throwing the spaghetti at the wall right now, trying to figure out how do we get growth factors to these hair follicles. I think growth factors will work, just not sure what the optimal modality is to get them in. And I don't think PRP and exosomes are it right now. Now, of course, in the United States, the FDA has put out a big warning about exosomes. I can't inject them.
Yeah.
And I also can't use some of the other technologies like Regenera not Regenera. I'm screwing up the name. I totally apologize. But where you take some of the fat from somebody's head, you do a biopsy, you grind it down, you purify it, and you re-inject. That's probably using growth factors and maybe some of the dermal papilla cells to regenerate hair. It probably will work, but you would definitely end up using all of your supply in order to regenerate the top of your hair because it takes maintenance. All of these things will probably take maintenance.
Yeah, I would say in general medicine, stem cell and growth factors are still to a degree experimental. Lots more data needs to be, I think, developed over the years to come, and certainly has promise and merit. But to the question Dr. Han asked, do you typically use these approaches as monotherapy, or as many patients inquire if they want to look for PRP or exosome solutions, should that be done in isolation, or typically do you marry that with medications to get best results? Do you have a thought on that?
I almost never do anything in monotherapy anymore. I used to do PRP monotherapy and exosome when it was available to me. We did inject exosomes. There was not enough evidence, even in my own population, and I probably followed a good 200 patients through 2 to 5 years of treatments with PRP. As a monotherapy, just did not see the benefit to equal the cost and the discomfort level. Yeah. Yeah. Now, I numbed patients' heads, so all they would feel is a little prick in the numbing. There's a lot of practitioners out there who don't numb at all. So
yes, I've seen that.
Yeah, and that's mystifying. We have ways of making it comfortable for a patient. Why wouldn't you? So I'm not sure if I would ever use PRP or exosomes as monotherapy. I would love it. It has a lot of potential benefit. You think, oh, I just get injections in my scalp, my hair loss goes away. Wow, that's such an attractive option. But I'm not sure it's panning out. Certainly not in my practice. Maybe I'm doing it wrong. Like Dr. Han said, there's so many different ways of doing it. There's no consistent, like a
protocol, no consistent protocol.
That's exactly the word I was looking for. Thank you. That helps us to, be able to compare one doctor's office to another. It just doesn't exist.
And it's interesting because even in a given treatment that is approved, such as a minoxidil foam or topical in a woman, we know how variable the absorption of that is amongst different women as well, right? And so even for the medications where there are protocols, we know what dose to use, as has been confirmed by randomized controlled trials. There's such variability in response, right? So I think when you don't have those protocols, you can imagine the variability is even wider. So proceed.
And we're talking about for hair growth here. We're not talking about for post-operative wound healing where the evidence is clearly in. We're not talking about exosomes for other treatment options. Correct. And I know that there's some ongoing studies even being done by friends of mine. So we're all just waiting for the data. It's an open question still. I'm not saying don't do it. There's,
correct.
If it's worth it to a patient and they have, the financial is not an issue. They don't mind the inconvenience or the discomfort. Well, then, add it to the list of things that we're going to try, but almost never as monotherapy.
And I will just say, Dr. Han, there are many patients, of course, that just don't want to be on a medication. So they'd want to try everything else they can outside of medications. And these do provide at least opportunities for some of those patients.
Yeah. And low-level light therapy with PRP. Yeah.
Dr. Han, before we jump on to, I know you've got a couple more questions and we wrap up. I just did want to ask a little bit about the approach to these treatments depending on types of hair loss, because we haven't necessarily discussed that. So TE in a young woman, would you typically try low-level light as your first, or would you typically put them on medication, or would you just counsel them to say, look, it's likely going to improve over the next 3 to 6 months? Maybe give us a sense of, for the key conditions in younger women, what's your typical approach?
I would add the medications in. It speeds the regrowth. You're right. Left on its own, it will very likely turn around all by itself. And in those women who are dead set against any treatment modality, well, you just say, don't worry. You hold their hand through it. You counsel them. It's gonna get better, and you can speed the recovery. There's some idea that, because hair loss is not life-threatening, that it's somehow less impactful to the patient, when the psychology and the research shows that that's wrong. It's way more emotionally impactful than people give it credit for. And patients might rate that, if they were asked, higher than something that was threatening their lives.
Yeah.
So we really do have to treat where we can. And if you tell a patient, because they were confused and they just need a diagnosis, hey, this is telogen effluvium, you're going through a big shed, it's going to regrow. Sometimes the relief of that, they're like, that's fine. As long as I know that it's going to regrow, I don't need anything. But for the vast majority of female patients, and Dr. Han can probably speak to this because she's experienced too, you need it to regrow as fast as you possibly can. And that's what's really going to help the patient the most. Plus, you're giving them some agency, something to do that will help it. Being helpless is one of those things that patients just hate. So even if you know it's going to regrow on its own, if you can give them something to do that will help it, that you have evidence for, obviously, to regrow it, then that's a good option. A lot of patients will come to me and say, well, can I do, microneedling, the home microneedling? Can I do, anything? They just want anything. And we'll turn them away from something that's going to be ineffective, like microneedling. And then sometimes they come back and they're like, well, I did it anyway, just in case, because they want to do something.
Yeah.
So giving them things that will actually work is usually the path that we take. And we almost never do just one thing. We almost never do, even low-level light therapy all by itself as monotherapy is not something we would probably recommend.
And I think one of the hardest things about treating hair loss is the time it takes to see an effect. And I think whatever treatments you use, I'm sure both Dr. Han and Dr. Wasserbauer, both of you, the real difficulty is patience. It's going to take generally more than 3 months, generally 6 months to start to see. And you're not going to likely see a maximal effect, perhaps even for 12 months.
Yeah.
That's a tough one for patients, isn't it?
Yeah.
Yeah, well, this is a good segue into the next part. I just kind of wanted to ask if you had any thoughts on ways that you can predict response rates for women that are going through, let's focus on genetic form of hair loss, so female pattern hair loss. Of course, you may treat someone that's 20 years old differently than someone who's 80 years old, but are there specific factors that you look at to look at predictability, or do you just sort of treat aggressively for most patients, especially if they're psychologically impacted by their hair loss?
Well, we will treat aggressively for most patients. And in order to give them some idea of their prognosis, we will use a few factors. Most readily, the thing that comes to mind is starting early. The less miniaturization percentage that you see. So we'll do a little dermoscopy and check out what percentage of the hairs are miniaturized, because they don't all miniaturize simultaneously. So if you look at the top of somebody's head, they'll have a couple of oak trees and then they'll have a couple of little saplings in between, and you get an idea of how many those are, what percentage that is of the total hair. Mm-hmm. And then for other patients, it depends on how many different cofactors they have. Do they have thoroughly uncontrollable thyroid? Have they, are they going through polycystic ovarian syndrome that is not necessarily controlled either? So if they have a significant number of cofactors and that's been pre-existing for a while and they have a lot of miniaturization, they're much less likely to have a robust response. But it's not something that we would decide not to treat just because
Yeah.
You know, sometimes any small response will be appreciated, and slow the speed at which the hair loss is happening. And by that, whenever I say hair loss, I mean losing the amount of mass, like the wood in your forest, not just the number of trees or the size of the tree.
Right. And I guess, like, what do you tell patients in terms of what their expectations should be? Like, what are the goals of therapy? Should everyone expect to have their hair regrow? Because I certainly don't give that promise to my patients, because it's such a hard condition to treat.
Yeah, I will tell them we'll see how much we can get, and move on from there. And we'll talk about other different expert camouflage options if they have significant hair loss that I don't think they're going to get to the point. It depends on the patient's expectations too. As you know, somebody who comes in and says, I just don't want to see my scalp anymore, that's not a realistic expectation. I mean, normal humans have scalp, so you're going to see something. We'll talk about scalp micropigmentation or use of the fibers, or even, adjunctive, non-surgical hair replacement. So it's not it's often a difficult conversation of, we can improve things. Let's work as hard as we can to slow this process and get you as far as we can. And usually we can get patients to a good place. Usually they're pretty happy. They'll feel their ponytails a little bit thicker. They'll see a little bit less of their scalp. They'll have more to work with when they're, coiffing their hair. So that's always positive. And any small improvement that you can make for a patient in something that's so emotional, it really will, make them grateful for the treatment options that you provided.
Yeah, I think you're absolutely right. Like, I think basically setting expectations that any improvement is success, and even also maintaining what they have as existing hairs is also considered success, because we know that this is a progressive condition without treatment.
Yeah, non-progression would be a win.
Yeah, exactly. No, that's great. I think we'll start to close off. And so we just wanted to close off with maybe some practical lifestyle tips. I think this is a very common question I get as a dermatologist, because, sometimes patients don't want to go on pharmacologic therapies. They're looking for ways that they can modify things in their lifestyle, whether it's, hair care, like, should I dye my hair less? Should I not use a curling iron? Do these things matter? Of course, we know that likely that can promote more breakage to the hair. But what are sort of some practical tips you offer patients when it comes to hair care or any lifestyle things that you talk about, like even coloring your hair?
Well, anything do that. Yeah. And I do color my hair.
That's why.
Do that makes our hair look good in the short term usually destroys it in the long term. So, heat, chemicals, brushing your hair when it's wet will promote fraying. But at a certain level, you have to enjoy the hair that you have, and playing with it is part of that. So I don't have a hard and fast rule. If you're coloring your hair every 2 weeks and you're making it, absolute white blonde, and you're noticing it doesn't grow longer than this, well, you've got breakage and you need to back off that. Most of the hair coloring formulations these days are not as harsh as they were back in the day when they just used straight hydrogen peroxide. And making sure, a lot of women lack B12, vitamin D, iron, and protein. We tend to go on these fad diets where we lose a lot of weight as well, like like you said, the current trends. Yeah. So anything you'd avoid, but getting those nutrients, using a shampoo a couple of times a week. That the 4 shampoos that I like to talk about being medicated, that actually we have scientific evidence for helping: zinc pyrithione shampoo, which is like Head and Shoulders here, selenium shampoo, which is like Selsun Blue, coal tar shampoo, which would be an anti-inflammatory. It's the brown one on the shelf. Neutrogena's T-gel, I think. And I'm not paid by anybody here, but the 4th one would be ketoconazole, which is an antifungal shampoo. Yep. You have to put them on your head and leave them for 5 minutes. They don't make your hair very nice, so you have to shampoo with something else after. And then condition as much as you like. There's one little nugget that I got from, again, that same hair researcher. Leave-in conditioners. Not often used here in North America. The rest of the world has been turned on to them, but we have somehow missed the boat. you need something that's going to be a small molecular weight oil or sterol. So like, what's a good example? Like coconut oil, emu oil is another one. So small molecular weight might actually be able to be absorbed by the hair shaft, and just avoiding all of that mechanical and chemical damage insofar as you can while still enjoying your hair. That's what I would say.
That's good advice.
That sounds like very sage advice. I think, Dr. Han, maybe just to before we wrap, a question we often get from both men and women, of course, as they increase levels, for example, of activity. You've talked a bit about diet. What about exercise? There's a lot of literature today on exercise and chronic exercise or intense exercise, perhaps being pro-inflammatory if it's excessive. Certain exercise boosting drinks and agents with creatine, for example, do they, don't they? Personally, I don't think there's a ton of literature that suggests, either exercise is bad for the hair or necessarily good for the hair. I think it's okay. Exercise has massive health benefits, so we generally tend to recommend it. And with supplements, probably anything in excess has the potential to do more harm than good, and including things like creatine for pre and post workout. Do you have any thoughts about exercise and or replacements in women, particularly who are suffering from thinning hair? Do you promote it? Is it up to them? How do you approach that when women ask?
Dr. Han, did you want to take that one first?
Sure, yeah. So, unless the exercise is intense that they are losing weight and doing it intensely in that regard, I don't think that it's really that harmful. Supplements, I get this question all the time. I agree. In excess is likely not great. It's not great for certain organs as well in the body. But a common question I get is the biotin one, because that is so heavily marketed and readily available and often is in a pretty bottle for women to want to buy. Collagen's another one. The evidence is, I would say the evidence for biotin is reasonable, but, at the end of the day, it's really looking at not regrowing hair, but it's improving the structural integrity of hair. So building that keratin and the amino acid building blocks that make up hair. So I don't really think it's that beneficial to regrow hair, but if you take it on label dosing, I think it can certainly be helpful for those that do a lot of things to our hair, like chemicals and heat application to the hair.
As with many nutritional approaches to treating disorders in medicine, a lot of the early data came from deficiency states. So biotin deficiency or zinc deficiency. We used to see a lot in South Africa, kids, particularly from the rural areas, with protein malnutrition, and they had very rapid and friable hair with rapid hair loss. So, of course, most people living in a developed society where they have access to decent nutrition are not going to be really deficient in nutrients. And so I think what you're saying is, probably can't harm unless it's really done in excess. And that's another thing, viewers and listeners should remember. Just because it's a vitamin doesn't mean it can't do harm. I've seen vitamin A toxicity and liver failure in a patient because of overdosing of vitamin A. So we got to take replacements also carefully in medicine and not do things really too much in excess. I think that seems to be your approach. Dr. Wasserbauer, do you feel similarly?
Yeah, I think Dr. Han really encapsulated it. Nothing in, not too much of anything.
Okay. I think one thing, though, that we are deficient here in Vancouver is vitamin D. Serum vitamin D levels in patients. I do think it is an important component to hair. So I will recommend replacement if patients are deficient. And most people are deficient here, even though they have a full balanced diet. And it's really related to the fact if they're not taking vitamin D fortified dairy or supplementing, and because of where we're located, unlike you, Dr. Wasserbauer, many of my patients are deficient in the sun, and so are going to have low levels of vitamin D serum when we check. So if
you do check, the vitamin D is not as much of a problem for us. You're right. The biotin, I don't mind if people take biotin. You're just going to pee out any excess.
Yeah.
But for the B12, I tell people you really need to take the sublingual. Just taking a pill, your gut has enzymes that destroy B12 before they get to the area that it absorbs it. So make sure you're taking an absorbable pill or the shot every 3 months. And then for iron, so I was a general practitioner and I missed so many iron deficiency hair loss diagnoses because we don't order the proper. There's a million different, you can order total iron binding capacity. You could order total iron. What you need to order is a ferritin.
Correct.
And you might get a ferritin of 30, but that's not frankly anemic until it's 20, but it is still affecting your hair. So you gotta treat the symptoms. Generally, I try and get the ferritin above 70 or 80. That's where I find that, wow, patients are suddenly growing nice hair again. But again, if they go too overboard, then they're taking tons of iron. That's a whole other, nasty bag. Yeah. So you don't need to go too much, but just realize that sometimes, even if you're not frankly anemic, it can still be affecting your hair.
And I think this is very important, particularly for premenopausal women who are menstruating. Obviously, just as a reminder, ferritin is a marker of your total body iron stores. So as Dr. Wasserbauer suggests, getting those levels, above that 60 to 70 range is probably a good target, particularly women who have heavy menses, heavy periods, where there is blood loss frequently. Dr. Han, any last questions from you before we wrap?
No, that's great. I want to be mindful of everyone's time. And I think we have lots of great content here that I think will be of really good educational value for our listeners. So a big thank you to you, Dr. Wasserbauer, for joining us and just sharing your pearls of wisdom after many, many decades of seeing this in and out. So really appreciate your expertise.
Yeah, I greatly appreciate your time today, Dr. Wasserbauer, and your expertise. You've actually helped, I think, demystify a lot of questions and make the complex a lot simpler. So we've been really, really privileged to have you with us, and thank you so much for your time. Next podcast from XYON is going to be on minoxidil, the comeback, everything you need to know and want to know about minoxidil, the clinical data, topical, oral minoxidil, how it works or how it's thought to work. So stay tuned, and we'll speak with you all soon. Thanks, everyone. Bye.